Welcome to Leadership and Culture in Healthcare, where we are in Series 7. My name's Matthew Winn, the podcast host, and I have probably one of the best known clinical leaders in the country, I'd say. He's wincing on screen at the moment as I say that. It's Partha Kar, who is a national director, but also a local clinical leader. Partha, welcome to the podcast. Why don't you start with describing what you do in your roles and maybe how on earth did you get to do what you're doing?
Yeah, no, thank you. First of all, thank you for the invite. Much appreciated and the kind introduction. I think when you say well-known clinical leader, it could be substituted very comfortably with the words notorious rather than that, but that's fine. So what do I do? Well, I hold a full-time clinical job in Portsmouth as a diabetes and endocrine specialist. So I do a job, my clinics and the rest of it with it. And beyond that, I have worked in NHS England in different shapes and forms as the changes have happened, which is about looking at diabetes, type 1 diabetes, technology, then also part of the GIRFT team as well, doing that work, which was fascinating in its own right. Beyond that, I do some work for the General Medical Council regards some international medical graduates and locally employed doctors and that side of things. And so a very portfolio. I have done work with the Royal College of Physicians. So yeah, a checkered portfolio, I would say, over the years.
And where did the kind of interest in the diabetes endocrine world come from that you ended up in that training and as a consultant in that space?
Yeah, I always pay homage to two people in my life, and I think it's important we don't forget who got us here. Very early days in my career in Worcester, and then previously before that in Dudley, there was individuals by the name of Dr. Tony Zalin, and then there was Dr. David Jenkins, fantastically inspirational people. And I think they drove me towards it in the sense of showing what you could do in a chronic disease setting. And I think they sort of inculcated in me the view that you could do a lot of work if you had the patient voice with you and genuinely sort of embrace that sort of approach. And I always use a line that I've learned from them, which is in your journey, be a guide, not a gatekeeper. And I think as a clinician and as a policymaker, that served me really well. So I always say, I suspect those are the two individuals who were very instrumental in me ending up in diabetes and endocrinology and training, and then subsequently consultant and the rest.
And in your employment in your trust in Portsmouth, do you have what kind of leadership roles are you undertaking within the trust, other than, of course, being a consultant, which is a leadership in its own right?
So I've had a history in Portsmouth. So just to give it, 2008, I became a consultant here. In 2009, I became the clinical director of diabetes. And those days were about trying to sort out the community slightly, I can say with a slightly ironic smile. The whole discussion in those days was moving care into the community and trying to build an integrated service too. And I know nowadays people, when they talk about neighborhood health and stuff, so a lot of people, it sounds new. Those of us who've been in the system for a long time, this is not new. It's just different iterations of the same philosophy, which we are trying to get to. So there was a lot of work in there. I did that work for about 6 years, 2015, nearly beginning of 2016 or thereabouts. I also did some work looking at the emergency stream in Portsmouth, early doors, which was about flow in the hospitals and gaps. And for those listeners, you remember those were the heady days of 98% 4-hour targets.
Indeed.
Yeah. I know. When we hit 97.4, it was allegedly a disaster. So, but there we go. So that's how times have changed. So I've done some work, also done some work in the community provider, just for experience sake, understanding about services and how it works in the community. I did a lead role there across some long-term conditions with, in those days, it was called Southern Health NHS Foundation Trust. So yeah, different organizations along the way. And but no, at the present moment, I just do the clinical work, help out with little bits and bobs in the trust, but don't hold a management role in the trust right now. Maybe in the future, but not right now.
And just to give people a bit of an indication then, because you've talked about making change, you just talked about urgent care world, long-term conditions, care at home. So from your experience, going back to those kind of 2000 period, what what is the role of the clinical leader, that clinical voice to drive that change? And how did you make, I presume you made some change because you was, but how did you make the change happen?
I think now my personal view is I always say there are 3 or 4 pillars on which the leadership journey sits, whether you're a clinical director or a national role. And I think the first thing that people look into is your vision. And I don't think a lot of people come with a vision. They come with trying to enact somebody else's vision, which is always a struggle because you may not believe in it when you're doing the job, and that's always shows. So having a very clear vision is very important. I think also, and I don't say this glibly, and I've learned this along the way, you need to surround yourself, and I take this freely from Roy Lilly, who I talk to from time to time, is you need to surround yourself with people who are better than you. And I think that's very important. And when people go, oh, you're just trying to be, and those of you know me, I'm not trying to do any humble brag on this one. That's not my strength. I'm genuinely been very fortunate to have clinical managers, data analysts and stuff. It's very important to have that. So when you're going in, you know people who are better than you in that field and you give them that sort of leadership role. So that's 2. And the third one is what I call putting a flag down on accountability, right? You need to say, I will stand for the team and I'll take the plaudits. So you don't just turn up to HSJ awards for take the prize. You also are there to take the media when things are not right. And I think that's very important because I think the team respects that you will take the flak on their behalf. So, and I always go back to analogies about good managers in sporting world, that the reason they stand out is not just their success. The reason they stand out is in times of difficulty. They are the ones you will always see. They're not just putting it on the players. They're like, you know what? It's my call. I made the call. And I personally believe that if you're a clinical director of a department, however small it is, if you have those 3 principles, this is what I want for the vision. I want to have team who are better than me, and I will take the accountability. You will garner so much respect that you will drive things forward because people may not like your style, but they will always appreciate that you are doing it for the right. At least that's what's worked for me in my career. And people have different styles in how they communicate, and you change as you grow older and as you learn a little bit more from other people. But I think to your question, I think those are 3 big principles, I would say.
And there is that element of which you must have been very conscious of when you were a national leader, because let's talk about your national role a bit, is you can write what you like from NHS England, but unless it lands locally, that point you said on my local vision for the South Coast diabetes management, slightly irrelevant. No offense to national colleagues in terms of the stuff they're writing. And were you always conscious of that in what you did nationally?
100%. I think, and I'll tell you, I've learned, I think let's be very honest. It wasn't 10 years ago, I would come around and I would say, hey, listen, there's a model in Portsmouth and it's amazing and everybody should do it. And I think you go over the course of time and learn that's a very simplistic narrative of that. You could talk about the principles, but every area's politics is different. The deprivation is different. The relationships are different. So you have to make those adjustments and you learn along the way. So I think there will be a slight, I wouldn't say the naivety, but I think it's the enthusiasm of youth, which would make you believe that that's only one way to do it. So I think I've learned along the way that there'll be different ways of cracking the diabetes, but I think that the concepts are the same, give or take. So I think I'm mindful of that nowadays, and I think doing the getting it right first time role also gives you a lot of insight into lots of different ways of working. Some good, some not so good, some driven by ego and hubris, some driven by general passion, some driven by data. But you learn. And I think you're very conscious of that when you're putting out national communications about there isn't one way to do it. And I think that sometimes is the dichotomy that I would say NHS England has suffered from, where they would say, this is only one way to do it my way. And there's a lot of local system leaders going like, well, would you like to listen to us? Because you have to put some nuances in play. And the problem happens when people do the override. And then everybody gets surprised when you have variation because you haven't listened to the nuances. So I think that's what I have learned along the way. And that's would be my advice to people is that if you can get that in your sort of armory, so to speak, earlier on, then you benefit from it earlier.
Mm. And I think that's a really, I recognise that when I was in the national role in NHS England, the tendency for people to want to overprescribe and set in detail, and it's like this just isn't going to work. There will be history, there, as you say, there'll be culture, there will be a whole bunch of reasons why people are doing those things, but let's all actually let's all aim for the same outcomes, and then you can get there in different ways. But it's again getting that balance right, isn't it? So let's just talk about your national role, because people will, who are listening to this, will have known you from seeing you write and talk and be the quiet flower that you were on the national stage around diabetes and about long-term management. What kind of induced you to go from being a great local person, clinician, to say, oh, I'll go and do the type 1 work nationally?
Yeah, I think there was two drivers. I think number one, I was in a meeting. I'll tell you, there was a big national conference. And I remember going up on stage and doing my thing, which is like, what do you all guys know? I still very clear, it was 2016 March or February. There was a big national conference, and I took the stage saying that NICE had written guidelines for type 1 diabetes, which were built in a fairyland. Nobody could implement it. What is the point of writing guidelines which nobody can get in their lives? And I even went ahead and I think said something like, apart from building some people's CVs and giving them professorship, what exactly has it achieved? It probably
pretty uncontentious then.
Yeah, absolutely.
Yeah.
There is actually a Medscape report where the chair said he had to have an infusion with vodka at the end of that session. But I wouldn't probably do that right now, but I think that was also that time I was like, come on, guys, what's going on? And I remember in the audience was the chair of the NICE committee who had written the guideline, who was one of the most respected, and is still one of the most respected figures in diabetes care, Professor Stephanie Amiel. And she stood up and said something to me. She said, look, I'm not going to answer your criticisms, but I'm going to just ask you one thing. If you're so passionate about it, why did you go and do it yourself? All right. And I said, you know what? That's a fair call. That was one. And I said, you know what? That's fair point. There's no point in being armchair critic if you're going to step up. So that was one. And the second driver was a meeting that I had with, at that time, who the medical director and CEO, which was Simon Stevens and Bruce Keogh. And they were interested in the work I was doing in Portsmouth because it was about integrated care that people were talking about. And we got chatting, and I think they were both quite instrumental in saying, look, you've got a very different style and approach to it. We'd like you to bring into the team. You've got a maverick element around you. And so I remember saying to them, yes, it is. But that will come with its own flack, because people react to that and people might complain. People might do that. And Simon and Bruce said that's fine. But I want you to keep the patient at your center of what you're doing. And here is your task, which is, and I still remember a running joke we had with Simon, which was the whole Mission Impossible theme, as it is in Mission Difficult, it's Mission Impossible. Because type 1 diabetes outcomes in those days, we were one of the poorest in Europe and amongst all the competing countries. And I think Simon had gone, or Bruce had gone to some conference where people had flippantly said, oh, UK, very good at doing research and academia and nothing about implementation. And Simon said to me, I just want you to make it one of the best, make it better. And what they did was also a leadership thing I learned, which I try and do now for people who are probably, I would say, less privileged than me. I said to him, it will be a difficult journey. People will get upset. And he said, I'll give you all the fire cover you need, as long as you don't insult people individually. You stick to the basics of decency, and you always do it with type 1 diabetes at the forefront of what you're trying to do. I will defend you. And he did. He and Bruce both did. So that probably are the two drivers which brought me into play. One was about that allowance of, spreading my wings, and the second was the challenge from such a respected person. So those were two brought me into the national play.
Simon and Bruce were asking you to work within a framework that potentially wasn't how you started in that conference, given you just slated your peers in terms of NICE guidelines. So give people a kind of view into you starting that life, because my hunch would be you'd pretty rapidly need to be around the table with that nice committee again,
Oh,
to who you've just publicly said, you're
yeah.
pretty wrong in this, folks.
Yeah. So I think I always say to people who are beginning their leadership journey, you need to have good mentors. And I don't say that lightly. And what I see right now in NHS England is a lot of people who don't necessarily have that mentorship or that experience in place. So I was very fortunate in my career to have Jonathan Valabji, who was already in place as the national director, really, really forward thinking, very calm. And we have always joked about us being the chalk and cheese or the Captain Kirk and Mr. Spock analogy. He's calm, he's collected, he looks the part, he's a professor, he knows his academics, and really, really calming influence that everybody respects. And I was the firebrand, and I would go to meeting, but he was a really, really good influence on me. And Simon made sure that I worked with Jonathan in those capacity. So Jonathan would open up a lot of doors for me, saying that, well, Partha's coming from a place where he wants to do this, and at the end of the day, so he also helped me explain to academics quite well that, look, isn't the greatest joy of your life not the paper, the fact that your science got into people's lives? And all the academics said, absolutely, that's so okay. So let's see what we can do. So I think that's probably another person I hugely would recognize in my journey, in the initial phases. And I think one of the best advice I had, so I joined NHS England in April 2016. And the best advice I had from Bruce was, Partha, for 1 year, don't say anything, don't write anything, don't do anything, just go and listen. That's what I did. I met with people, and he gave me this really good advice, is that don't do things online, meet people off with a coffee, be sociable. And that was worth its weight in gold, is meeting people just one-to-one for coffees, explaining your vision, people who would perceive you differently, academics who would have in those days go like, well, who the hell is this young new upstart who's turned up trying to solve diabetes when none of us have done it? But it was really, I think those advices I had from those individuals were really helpful. So 1 year I did, absolutely, honestly, for 1 year of my leadership journey, you will not find anything in the literature, because I was genuinely just sitting around, listening, talking to people, meeting different people, and meeting different teams. And a lot of the time was spent meeting people with type 1 diabetes, just trying to understand what would land the best, what would be the one thing we pick. When Simon said, put your flag in the ground, make your call, what are your priorities? And that's where the technology journey came from, because a lot of things came from, how could you improve self-management? We couldn't just throw more staff at it due to many, many reasons, which has been rehearsed many times over. So what could you do to improve self-management? That's where it came from. So 1 year of that, to your question, I think tempered me, if that makes sense. Didn't lose the fire, but yeah, I think it gave me much more insight into dealings with people who I need to speak to, etc.
And it's interesting, isn't it? The perceptions of those national roles, I often find, are quite bizarre. Almost, you can do things nationally to make things happen with ease. And you've just described what I know is the reality as well, is it's quite the reverse. It's actually building relationships. You need people to understand Partha and your credibility. And actually what you just described is a dynamic that I don't think is done enough, is what's it mean from the patient perspective to get this right? Because otherwise we might as well not get out of bed. That's the litmus test, isn't it, at the end of the day?
I think, I don't think it's done deliberately, but I don't think many people quite appreciate how less people are involved in their decisions about them, right? And I think that's an NHS thing that we have done over the years. And when people always go back and say, what do you owe the success to? I always say this, it's the community of type 1. If I didn't have them behind me, I wouldn't have the strength and the power and the push to get it through so far. So that's really important. And when I say that, I think also the other thing I would say, when you're talking about people with lived experience, whatever your field be, right? There's a lot of leadership which tend to gravitate towards only the charities. That's not the only place, right? Charities have got their own politics and their own visions and their own priorities that may or may not match what the people they represent, because that's how all organizations work. That's not a criticism. That's how it is. So I think I learned that quickly, that you have to go out beyond the charities and stuff. So I think that's one of the takeaways I say to everybody, is that genuinely take time. If you're serving a community, genuinely sit down, go for a coffee, sit down with a group of people, or listen, join in. And I think people don't spend enough time building relations. This is and it may be because we're so much rushed because we have to get things done right now. But that's been my sort of learning. As I said, year and a bit was spent just doing that, nothing else.
And so for people that aren't, I'm sure most people listening will be, but those who aren't au fait with what effect and what the impact of that work after your kind of first year of assimilation, how would you boil that down and describe that to people?
Okay, so I would say any chronic disease, I'm going to leave out the nuances of type 1 diabetes or diabetes per se. Any chronic disease, to me, sits on three planks, I always say, which is self-management, peer support, and access to trained professionals, right? The problem we have in the NHS is that we tend to throw a lot at trained professionals. Then we run out of trained professionals. Then we have a debate about who even is a professional and are they trained. So at the moment, if you see the workforce debate, it's all about this debate. Are people trained enough to look after me? What on earth is going on?
Yeah.
Well, the reality is that with the best will in the world, these people with long-term conditions will actually be in the health system or be in touch with the health system for about 0.02% of their lives. That's the reality. 99.99% they're on their own. So the philosophy that I went for is that what can I do to improve self-management and peer support? So the whole work has been geared towards how do I get the community to talk to each other? So we build lots of peer support wings with lots of peer support events. And then technology. So just for the listener, if you think about diabetes, normally what used to happen or does happen in lots of parts of the world, you have to prick your fingers, which in itself is a painful thing. So the best evidence will tell you to get the best results in your glucose, you need to prick your fingers 10 to 12 times a day, which itself sounds quite horrific. So guess what? Most people gravitate towards, I'll end up doing one or two times a day. Now, we then move it towards a system whereby you don't have to do any of that. Your glucose just appears on your phone. So the best analogy I give, if you were in outer space and you never heard of Usain Bolt, and I show you 4 pictures of Usain Bolt, you will see, a lovely strapping man with we just got pictures of him running. I show you a video of him, you're going like, Jesus Christ, this man can run. And that's the only difference between what I've just described to you. You have 2 finger pricks in a day, which gives you no idea what trends, what's happening. And you have a continuous video. So guess what? You can see what's happening. You can change your lifestyle. You can change your insulins. You can do whatever you want. You know what exercise does to you. And guess what happened? Everybody's diabetes improved. So impact-wise, 10 years nearly down the line, we now have some of the best results across Europe, some of the greatest access in technology. Our pediatric data is pretty amazing at the moment, and really heartwarmingly, ketoacidosis admissions have gone down, but congenital malformations have gone down in babies, and admissions to neonatal care units have gone down. So it's been a whole turnaround, which has been good to see. And I always say it's not been achieved by throwing more and more staff at it. It's just been achieved by helping people with self-management. And peer support. So that's pretty much a nutshell of what has been achieved. And I think facilitating that process through, putting it through the different wines of NICE and MHRA and GERF, this and that. There's so many bodies. But yeah, that's been my role has been to facilitate that maze to get that through.
And what's fascinating listening to you is you've made that just so beautifully simple. You made it, there's 3 elements of any long-term conditions, but obviously your experience on diabetes, and the changes have happened essentially because you focused on how the individuals support themselves, support others, and use technology well. And wonderfully simple. An interesting observation is that's very on NHS England. That's terrible syntax, but you get my point, because NHS England is just historically grained to say, I give you lots of guidance, I tell professionals what to do, I put in a situation report that I can analyze that to the inch of its life, etc. You've kind of turned that on its head and say, actually, wrong end of the telescope, haven't you?
I've always said that. I think I've always observed NHS in different other areas, right? And I say this not flippantly. I say a strategy of, here is some data, can you please do better, is not a strategy. in American football term, that's a Hail Mary pass. That's like, I wish things will improve. So if you're then going like, why aren't things improving? Well, that's because that's not a strategy. I think good data is a good step forward, but you need to guide people through the data. And I always use the analogy of, in my experience, there are 4 groups of clinicians you will meet when you're trying to make changes, right? There'll be a group of people who are like, when you bring something new and they're like, absolutely, Partha, let's do it. This sounds great. Let's do it. Then be a second group of people who are the majority in this country will go like, well, that sounds interesting, but what's the evidence? What's NICE said? What have they said? Because they have a huge amount of faith and respect for NICE. There'll be a third group of people who are like so bored with life and their life is so busy. They don't have time for any of this. They're going like, just tell me what to do. Is everybody else doing it? If everybody else is doing it, I'll do it, man. And then there's a fourth group of people who go like, I don't believe in this. The way I worked in 1965 is fantastic, and I don't think anything needs to change. And what we in NHS England or central teams don't appreciate, there are 4 different groups of people with different personalities. Now, if you're going to throw one style at everybody, it's not going to work. How do you convince to convince that second group? You need data. You need to show them, guys, this works. To convince the third group, you need to show them, guys, everybody else is doing it. It's not about data. You need to show you are like, do you know everybody else is doing it? And they're like, oh, okay. And the fourth group, you need to tackle very differently, right? So if you don't have different strategies, so I give you one example. I was talking to somebody about this the other day, and I said, if you look at the concept of pilots that we have in this country, why do pilots fail in this country? It's because we throw out pilots, and it's only the first group who does it. Well, of course they will succeed. They're so enthusiastic. So when you then
they want to do it. Yeah.
They want to do it. So then when you take it to group 3, they weren't convinced in the first place. So what are they going to convince anymore? So I would actually turn it on its head and say, you need a bit more of group 4 in the pilots, right? To basically people say, I don't want to do it. And go, oh, come on, man. Let's see. We'll guide you. We'll give you money. You need more of the group 2. So group 1, you don't need. So I think our strategy, going back to our lenses, sometimes becomes very traditional. So we really struggle to do things at scale in this country, though it can be done. I think the NHS is full of really good people, good clinicians, good managers, really good people in my experience who want to make, and I just find it mind-boggling that a lot of these people are frustrated because they would like to do better.
Yeah. And it's interesting. I remember doing some training last year, and it was on inclusion, and it was a good thing to do. And the trainers had a lovely phrase of, if as a leader you're leading and no one's following, you're just going for a walk, by yourself. No one's following you. And so that whole thing of, great, let's get all those pilots going, but if no one's following behind you, then you've wasted the energy. And
I think we're also not big fans of challenge. I think that's a problem. And I think it's a very unique thing. I think it's a very unique NHS thing. I was going to say it's a very British thing. It's not, because I've worked at different other industries whereby when you challenge a leader, they take it very personally. And you go, no, I'm not challenging you as a person. I'm challenging your leadership role. So I was having this discussion with somebody and I said, if you are leading cancer care, where does the accountability finish? That cancer care is not improving. The response was, well, the person is a fantastic person. I said, I'm sure they are, but I'm sure they're amazing. But you missed my point. I'm saying that something has improved, something has not. So what are we now doing to help that person get it? So I think it doesn't progress. And then what happens, in my experience, in a decade, we do a lot of echo chamber things. And I've been part of it, where you go there and say everything is, and it feels sometimes like, and I say this tongue in cheek, it feels like you walked into a Lego movie where everybody's singing the Everything is Awesome song with Everything is Burning. And you go like, what is happening? So there is a lot of that. And I think that stops a lot of progress, because you very rarely see national meetings where people are open to challenge. Right? Because if somebody came to me and said, Partha, list the 3 things you think you haven't done well, I would happily say it. I would happily put down, do you know what? I failed at these 3 things. I tried. And I think the next person needs to take that battle up. And I can tell you about my failure journey so they don't do the same thing. And I don't think enough of that happens in NHS England or DH. And so we get stuck in a rut. So the next person makes exactly the same mistakes. So, yeah. that's an organizational memory, as you know, is, well, that just doesn't exist. So yeah.
Yeah. And yeah, just to slightly balance what I was saying earlier, I mean, there's some good things that NHS England do, but I think you've put your finger on it. It's not a British thing. We can be very critical. We could be very challenging of different things, and look what we do to our politicians, frankly. But it's about, the NHS is not sacred. The NHS is here to serve and support the population to be living healthy and well lives, and support you in times of great illness. We desperately need that to be challenging in terms of, are we doing it the best in class, don't we?
Yeah, absolutely. And I think, as you said, you hit the nail on the head. It becomes a very polarized debate. So if you say, look, we're not doing very well, it's like, how dare you say that? Do you not love the NHS? And you go like, no, that's got nothing to do with that. Right? I don't know. Of course I love the NHS, but I can't say we're not doing well in X and Y, right?
Yeah.
Because, and I think that's what the common public get frustrated with, when they go like, look, I can't see my this or do this, or I'm worried about my cancer care and maternity care. And when leaders go like, no, it's okay. And you go like, what? So I think that honesty isn't there. And I'll give you one very good example, which I keep talking about. Our workforce planning in general is a mess, right? But what would go down really well, in my opinion, amongst the staff, if somebody came out and said, guys, we haven't done well, right? But what you see is that we had a long-term workforce plan, which came out in 23, which got ditched by 24. So that was the end of that long term. And now we're going to have another one in 26. But what you need is people to come out, in my view, like people, the top of the people, look, guys, we botched it up. And we're going to try our best to get it right. But you don't have that. So people are skeptical already of the next workforce plan, which is not a really good start. So I think that sort of humility needs to be more, I think.
Yeah. So, brother, let's just talk about, for the last section, on what sustains you and what allows you to be in that leadership role, whether that's locally or in the national things that you've done, because there's a lot of energy expended in what you've just described. There's a lot of energy expended in a great clinician, because it's busy and it's frenetic and et cetera, et cetera. So how as a leader, do you get that balance right to be that optimistic, let's get this great clinical leader mentality across in all that you do?
I'm a massive believer in a concept of what I call bubbles, right? You need to have your own bubbles, which is discreet and away from the frenetic nature of your work. They're short. They could be your small group of friends. They could be a family. And I think switch off is incredibly important, right? People will see pictures of me of going traveling. They're, oh my God, how many holidays do you have? I have exactly the same holidays as everybody else. I just take very small, short ones to take a break from everything. And I think I surround myself with a small group of friends, but who are my genuine well-wishers and friends who let me take my mind off everything. And I don't, so work, a lot of us tend to take work home. I have seen colleagues working from their holidays because they just have to jump on a call. And I would like to say this to everybody, none of us are indispensable, none of us. And you have to give that time to your family and your friends, just for your own sake, which was not, of course, for them, and you want to see your kids grow up and all that. And I cannot explain enough. So my bubbliness comes from the fact that, don't get me wrong, I have had really tough nights when I sit there wondering what is the blinking point of doing any of this anymore. I have had low points, I've had difficult times, but I have had really supportive people who go like, let's just drop things and take a break. Let's take a break. So that's important. I'm now, as I said, a decade, I'm probably the longest left clinical leader in NHS England. And there's a reason I'm there, is in spite of my outspokenness and my headache that I give to media teams all the time with what on earth is going to Partha come up with next. But I will always, so my advice to everybody is genuinely take your breaks. A break should be a break, right? And good friends, good family, even your own times. You might just enjoy watching a movie on your own. You might just enjoy having a break on your own, reading nice books. But you should be away from work. And that's the sustainability. And the final bit I would say is that people is also what drives me. I generally see it as a job which I need to finish, right? So when Simon said to me, I want type 1 diabetes outcomes to be better, I always say to people, it is my job. I get paid to do my job. I will do it to the best of my ability. I'll leave 110% on the field, and I'll succeed in some and succeed in not. So that's what drives me, because when I hang up my boots, which I want to do in March from the national role, I will look back and I feel that there'll be some successes, there'll be some failures, but I will be, I think, reasonably proud of the legacy I'll leave behind. And I think that's the journey.
And when you, Partha, think about leadership to deliver what the government is asking us all to do, and you said earlier, just going back to the beginning of the conversation, some of it is slightly back to the future, isn't it? It's kind of stuff that has been around, but wanting us, I think, to do it on scale and to standardize them for everybody in England to get the good outcomes. What's your observations about the clinical leadership we need in that space, especially with your experience around comorbidity and disease management? What would you be saying to areas that they must have to make it successful?
So I think two things. I think, first of all, I think we're really bad at prioritizing. And I think there's too many priorities in systems to handle, right? Because everybody has got a priority they want to throw at you. And I reckon being honest with everybody is quite important, right? To say that this is our priority, gun A, B, and C, okay? And if that means saying that, I think that honesty needs to be there, is that this is what we are focusing on. We want to improve maternity care. We want to improve community delivery of care. If those are two big guns, we need to throw all our resources at it and the intelligence at it and our clinical leadership at it. But I think what frustrates people is when people are not honest that that's what our priorities are. And I think a lot of times we're also doing those, and you go like, but you can't. You don't have enough staff or leadership. That's my first advice. And the second thing I would do is I would put a lot of emphasis on, if you look at our numbers as to what actually benches the system, if that makes sense. It's people with long-term condition, multimorbidity. That's the whole population doesn't arrive in the NHS. I think we need to have a lot of focused approach on self-management, which we don't do very well, right? And we believe there's one tool that suits everybody. So how do you do that? It's just to give you one example. If you look at my world, a lot of people say, oh my God, adolescent diabetes is really bad. What we need is more nurses and doctors. No, the evidence says you need more youth workers. Because they are better than any nurse or any doctor at doing the thing of reaching out to these young kids and helping them out with their troubles and stuff and everything else. So I think those are the bits that we need to think about. And if we did that, I think we'll make progress in delivery of what we are trying to do, because the intention is very good. There's no question about it. It goes back to the point that the 10-year plan is now the 8.5-year plan. Looks more like a wish list rather than how to do it. And that's the criticism that we need to counter as leaders, I would say.
And final question, Partha. You're stepping down from the national role. You're clearly going to continue being passionate locally on the South Coast about what you do. What's the next thing? What are you excited about as that clinical world to get right in the next period?
So I'll be very honest with you. I think the UK, I've had a long thought, and I've been approached for a few other roles and stuff, which I mostly said no to. I tell you what I want to do. I believe that I have got a truckload of experience of the system and some ways of navigating the maze, and I would like to help people with that. I do already mentor a few leaders. I'm very happy to share the plus and minuses of that. That sort of thing really attracts me. I think we could do more of leadership mentorship, which I would like to provide. I think I would like to be in that space and help people. So I have taken on a role in India, which is more about different, and that's sort of giving back a little bit with charities and stuff, which I'm really enjoying. And I'm 52 this year, so time for the younger guns to sort of blaze. I would say.
You're still young, long time retired, as I was chatting to someone at the weekend about. And interestingly, our first episode that we published on this series was with Tony Young, who does all that work on innovation. Is interesting that he said virtually the same, is, I want to be able to support others, mentor, guide, help people in their leadership journey, because it's the only way we can elicit change.
Yeah, no, absolutely.
Yeah. Partha, it's been fascinating listening to you, that consultant role, work with the General Medical Council, NHS England, having that kind of real interesting clarity about local vision, make sure use and have fabulous people around you, be accountable to make the change. Your approach that you took in the national role, listening, understanding, but then focusing really clearly on self-management, peer support, and getting the right trained people involved, not just leaping into a clinical intervention to get type 1 diabetes cracked, as you have been very successful in leading with other people to get right. And you just gave lots of people a kind of really interesting perspectives on sustaining that leadership, living in those bubbles, taking time to decompress, but also really being clear that we're all very different and we all have very different motivations. And from policy terms and from leadership terms, the important thing is to get all that right, but always be focused through that lens of, does it make a difference to our local residents? Because that's the only game in town. Partha, it's been a delight talking to you. Thank you so much for coming on to Leadership and Culture in Healthcare and sharing your views on clinical leadership.
Thank you very much for the invite.